Well, thank you very much. Thank you to the organising committee and to Dr. Breen for inviting us to give this presentation. I'm hopeful over the next 10 minutes I'll enthuse you to set up your own practice in chemosaturation, and I'll show how the technology has evolved and the resources you need to set up a local service. The technology actually evolved from a surgical technique. The surgeons would isolate the liver by using clamps on the celiac axis and clamping the cava above and below the hepatic vein confluence, and they would infuse chemotherapy that way. And they demonstrated very elegantly they got very good tumour control in terms of tumour response rates of 70%. The issue was that it was a very invasive procedure and therefore wasn't something they were easily able to reproduce. The endovascular or percutaneous approach clearly is something that can be repeated multiple times. We've treated patients up to 8 times. Balloon in the IVC and one in the right atrium. A catheter with fenestrations between for aspirating the hepatic vein outflow. Standard arterial access to infuse chemotherapy. And then a filtering circuit, so a vena-venous bypass circuit with a charcoal filter that removes the chemotherapy. So the patient doesn't get the systemic effects of the drug, they get the local effect in the liver where they obviously need it. To give a bit of a background to our treatment centre, we've treated over 300 treatments, all in patients with ocular melanoma, standard workup with CT and MR. The patients are all treated under general anaesthetic, but they go to standard theatre recovery for a few hours post-procedure. No high-level or intensive care beds needed. Length of stay is down to about 2 nights now. All patients getting bone marrow stimulation with pegfilgrastim. Post-discharge, they get a full blood count every week for 4 weeks. And we've got quality of life data, which we've submitted to ASCO, has been accepted, that shows people return to baseline by about 3 weeks, so very well tolerated procedure. Who do we exclude? The main group we're trying to exclude are those that are at risk from the cardiac strain of this technique, so anyone with significant ischemic heart disease, arrhythmias or a lower performance status would be excluded. Sometimes we're using CPET testing to establish who we should be taking on. The other issue is that you're fully heparinized for the procedure. So anyone that's at risk of bleeding disorders or bleeding tendencies, we would have to consider carefully. The important thing to realize is this needs teamwork, and the important members of the team you won't be used to working with. Cardiac perfusionists need to be fully on board for this treatment. You also need oncology pharmacy working closely with you. The drug has a short half-life, so they need to facilitate delivering the drug just when you need it. And otherwise, much like most of our practice, you need intensive care consultants and you need medical oncologists on board. Now I'm just going to run through a treatment just to give you an idea of what it looks like in practice. So standard general anaesthetic, normal routine neck access, that's for the return sheath. Down below, so we have a large venous sheath on the right side, so it's an 18 French venous sheath. On the left side we put an arterial catheter. I normally use a 6 French vascular sheath. That means we can transduce the side arm, so rather than putting a separate radial artery line we can use the venous sheath. And then it's standard angiography. If you look really carefully you might notice there's some corals and a GDA there. Now we wouldn't bother doing that now, but this was earlier on a few years ago in our practice. Once you've got your guiding catheter and your microcatheter in place, the patient's fully heparinized. So you get the ACT above 450, and at that stage you can start thinking about using the venous catheter.
The main lumen, and then the contrast channel. At this end, you got 2 balloons, and you got the fenestrations on one side. So we take this catheter.
So that's the venous catheter. You can see us putting it in here over a wire up in the right atrium. Once you can see on the fluoroscopy screen there running it up into the right atrium. Remove the wire, and then
Rachel.
you're going to inflate those balloons.
Yeah.
This is connecting up
comes
onto the
the bladder
venous
stop.
bypass
That's
circuit.
good.
So
Okay.
clicks together. You've already
So let's go on.
treated the perfusion circuit with heparinized saline. You start drawing the blood down. That's running through the pump head, which is at the bottom of the circuit there. So this here is the pump head.
Drawing okay.
There's a flow monitoring device just to give you an idea of the rate of flow you've got. So the blood's not going through the filters at the moment, it's coming straight back to the patient through a bubble trap. So you've got a circulation of blood there, but no occlusion at the moment. So once you're happy with that, you've got good flows. We then inflate the balloons. So you've inflated a balloon here in the right atrium and one in the IVC. And we now do a venogram to make sure we've got good occlusion. So we inject retrogradely through the catheter. You've got good occlusion, there's no leak of contrast and therefore no leak of chemotherapy.
So blood's going to come up through
and we can now
slowly.
push the blood
Take
up through the
about 2 or
filter.
3
So we're
minutes
pushing the
and
blood
it'll
up
come
through the
top.
filtering circuit and back to the patient. This is the chemotherapy, so we're using melphalan, that's an alkylating agent. We use 3 milligrams per kilogram. We dilute it in 500 mils of saline and we inject it using an angiographic pump. So that just gives us control. It means you can inject from different places in the liver according to the distribution of tumour. And once you've got the chemotherapy in, we then have 30 minutes of washout. So we keep the filtering circuit going for 30 minutes after the infusion,
Bottom
just
balloon's
to make
down.
sure all that chemotherapy is
I'm
out.
taking down the top balloon.
So at the end,
Top balloon is
we
now
take the
down,
balloons
so
down.
we should start getting some return. And then
we
I'm
pull
going to
those
remove.
catheters out. And once you've got the catheters out, we can then think about giving protamine and reversing that anticoagulation. So that means the whole circuit can be disposed of, giving the protamine slowly.
We'll have a background in
And
recovery.
once that's done, we pull out the venous catheter and press, and we use an angiosil from the arterial catheter. And then a couple of hours later in recovery.
Hello, Ruth. How are you feeling?
Not too bad at all, actually.
Not too bad. Good. Well, it's, what's that, 2 hours? 2 hours after the procedure. Any tummy pain?
No.
Good.
And that's a fairly standard recovery. You know, the patient will go home the following morning, but she's only 2 hours post-procedure. She's sitting up and no doubt will have had a cup of tea and a sandwich in an hour's time. So where is the evidence? Well, the evidence at this point in time has primarily been in ocular melanoma. This is the published data to date. This was our original paper back in 2018, at which time we'd treated 51 patients. We've now just had our paper accepted with 100 patients being treated, 300 treatments. The other bit of important information is the focused data. We've got some early data from that. We know the overall response rate and we know that the progression-free survival is significantly better in the treated group than the best alternative care group. The full data set is coming out at ASCO and I think that'll be critical to leveraging funding for this group of patients, given that it's a well-performed randomized data set. The other thing I would say is this treatment is evolving and little incremental changes are making a difference in the safety profile of this technique and the efficacy of this technique. Our paper has been accepted for publication in Melanoma Research next month. That's available online, free to print. 250 treatments, no 30-day mortality. Complications, grade 3 and grade 4 toxicities occasionally, no grade 5 treatment-related adverse events, and a better safety profile between the later cohort relative to our early cohort. In terms of conclusion, what I'd like to say is that I think this technique is now showing good safety data and excellent response rates and disease control rates in a difficult to treat tumour type, that's ocular melanoma. The technique is fairly simple in terms of skill set and I think applicable to any interventional radiologist. You just need the right team and you need to get that team together. We've got good patient data and quality of life data. We're publishing some at ASCO. We're not using intensive care or high level beds, so this is much less source dependent, and there is evidence coming online for this treatment in other tumour types.